And good evening, everyone. Today's edition will be about perioperative pediatric fluid therapy. So during or pre or post operatively, what fluids and how much a kid should receive for different types of surgeries. Okay, now watch till the end. It's not going to be boring. I'm going to have a case-based discussion. So visit my website Pain Free Partha, my YouTube channel Pain Free Partha. A child is coming for surgery, okay? Why should there be some problem in fluids? Starvation, anesthesia, and surgery. These are the three things which come into play. That is why the fluid is needed for child. Whenever anytime we give fluids, it is about resuscitation. That means what has happened in the past. Maintenance to provide water and electrolytes that is going on in the operation. Replacement, for example, blood loss, evaporation. All these things has to be replaced. So this is all about resuscitation, maintenance, and replacement. The replacement is mainly going to be blood loss. What is the aim? Stabilize volume status, correct electrolytes, cardiac output, thereby the oxygen delivery. This is about one part. The second part is about hypoglycemia. We have to prevent hypoglycemia. See, this is the difference between pediatrics and adults. So oxygen delivery optimization and prevention of hypoglycemia, these two things come together whenever you are talking of perioperative fluid therapy in pediatrics. Why we need to worry about pediatric fluids? Because children have a higher metabolic rate. Surface area to weight ratio is higher. Faster respiration, extensive fluid loss. That translates into higher fluid requirements. Normally, it is about basal metabolism, is about resting energy expenditure. This is what they say is about 54 calories per kg per day at 1 year, which comes to 26 calories at 18 years. What are the differences between adults and pediatrics? Infants lose and gain rapidly heat. That is large surface area. We are talking about surface area is larger to weight in the previous slides. For example, now a 70 kg man is having a surface area of 1.73 square meter. Okay. What that happens to adult is going to be 35 means he will have 0.89. But a pediatrics 35 will have 1.1 or 1.2. That is the difference. Weight, surface area is more, the ratio is more. So they become more susceptible to this heat loss and gain. The larger surface area facilitates fluid loss. Medication dosing. The higher surface area, see here, difference in dosing. The skin integrity, delicate skin, vulnerable to injuries. The intracellular fluid accounts for 2/3 of body water, around 24 weeks of gestation, close to 80%, but it comes to 60% in adults. Another is interstitial fluid has got lower proteins. So then comes the Gibbs-Donnan effect. What is that? Sodium chloride is same here, sodium and chloride is same here. But there is a fluid movement here and there, depends upon the protein content. That is important. Lower proteins. Now what we have analyzed is children have got large surface area. Children have got easily heat and loss and gain. They need more fluids. They are more for decreased cardiac output and oxygen status. They are more for hypoglycemia. These are the points, some of the points which we have grasped so far. Now, what are the problems in infant kidneys? The GFR reaches adult levels only by age of 2, but that is why many times I take this religious circumcision. at least 2 years. So things become better with regard to kidney and liver. The low GFR is decreased capillary surface area, high renal vascular resistance. The other thing is the concentrating ability is low at birth. Now, we are decreasing the fluids. We have given less fluids for adults. The adults concentrate better and retain things. But the pediatric child cannot do up to some age. So concentrating ability is less. So they become the fluid water deprivation can cause more problems. This is the most important thing. 4-to-1 formula. Everyone knows 1957 Holiday and Sagar published. That means less than 10 kg, 4 ml per kg. 10 to 20 ml, 20 kg, another 2 ml per kg. More than 20, so 1 ml per kg. 10, 10 to 20 and 20. Now you see 9 kg per son. 4 to 1. 9 into 4, 36 ml per hour is the deficit. We know that. 9 kg, 36 ml per hour. 16 kg means first 10 kg we have to into for it 40. The second 6 is 12. So it is 52 ml per hour. Now 25 kg is 20 to 60 ml. Another 5 to 1 ml. So 65 ml per hour is the deficit which we need to correct. So that is what is called Holiday-Sagar formula. Postoperative ADH and hyponatremia. So there was a problem with hyponatremia causing osmotic diuresis, progress to hyponatremic encephalopathy. So that is why we were wondered, oh, what happens? Then one fellow really called by name O. Then he said he modified only 20 ml for the first 10 kg. Instead of 4-to-1 formula, keep it as 2-to-1 formula. This was post modification. Now, preoperative fasting guidelines, we know heavy solids 8 hours, solids 6 hours, breast milk 4 hours, and clear fluids up to 1 hour. Now we are saying sip as you go. Sip some water as you enter the theater. So this is clear fluids can be up to 1 hour. Why? Gastric emptying is 1 hour there. So if you give clear fluids in 1 hour, it will go out of the stomach in 1 hour. But in adults, it's minimum 4 hours. That is the major difference in pediatrics. If pre and post-operative fasting times are per fasting guidelines, now we have fasting guidelines, 2 hours fluids. And perioperative IV fluid is not necessary except neonates who undergo short procedures. Maybe 10 ml or 20 ml per kg in 1 to 2 hours is what is needed in most of the cases. For example, a normal 15 kg person comes for a short surgery. We need not give fluids or give 15 and 150 ml over a period of 1 or 2 hours and finish it off. So volume of pulse and distal pulse matters. Now we have weight loss, deficit, BP, pulse, respiration, skin texture, anterior fontanelle is sunken. All these things we know. Appearance, urine output. All these things we know because these are given in textbooks for even for diarrhea, burns, everything. So it is about dehydration. High tech, that they approved pulse pressure variation, stroke esophageal, Doppler indices. They have got inconclusive evidence or conflicting evidence. Now I can say 5% dextrose, 4% dextrose, this is 1/5 saline, this is half normal saline. All these things you see here are hypotonic. Only normal saline, finger lactate, Hartmann's, plasmolite are isotonic. Albumin, gelofuscin are also isotonic. So hypotonic, dextrose. Saline, finger lactate, Hartmann's, plasmolite are isotonic. Babies need isotonic fluids. What are the isotonic fluids? Finger, Hartmann's, saline, commonly. Neonates and infants less than 6 months who are fasting for surgery, they should be given glucose. Sorry. where there is an dextrose. When you preterm, neonates, especially preterm, children receiving hyperalimentation, for example, parenteral nutrition, children with liver failure, endocrinopathies, for example, diabetes, thyroid, after full day of fermentation, for example, you are given a GA and you are given a caudal block and you have also infiltrated the skin and completely deafferented, probably the stress response is less. So your catecholamine secretion of the kids is less. Maybe there we can supplement some dextrose. 1 to 2% glucose to intraoperative maintenance fluid is sufficient. Just add to the saline 1 to 2% glucose without causing hyperglycemia. How to do it? 2% means 2 grams per ml. 1% means 1 gram per ml. But 1 gram will only give 3.5 calories. Then this catabolic state will take care of this. As a guide, insensible loss for superficial surgery amount to 1 to 2 ml per kg per hour do not require special replacement. But if you do a thoracotomy, if you do a laparotomy, you may need to give 5 ml per kg per hour, or it may go up to 10 ml per kg per hour for a big laparotomy. 30 kg child, 60 ml per hour is okay for superficial surgeries. But you need laparotomy, then you need to have 10 ml per kg per hour addition. So 30 kg child may need up to 300 ml per hour. So if you don't know anything, start with 10 ml per kg per hour for major surgeries. Normal saline with 1 to 2% glucose, oral with 1 to 2% glucose, or hydroxyethyl starch. Both are okay, but HES is cheaper with albumin, but more allergogenic. Now, how to make this 1%? Somebody is telling 1% glucose, somebody is telling 2% glucose. How to make this? 1% means 2 ml, 50% plus 10 ml glucose. You see here, 100 ml saline. If you add 2 ml glucose, 50%, then it becomes 1% glucose. Now you see, 50% glucose is not available in many pediatric theaters. So what we need to have is 4 ml of 25% dextrose is 2 ml of 5%. So you add 4 ml of 25% dextrose to 100 ml of saline, then you are coming with 1%. This is enough. 100 ml saline, add 4 ml 25% dextrose, then you start giving 10 ml per kg per hour if you have a laparotomy. Auto transfusion measures are most reliable means passive leg raising, external hepatic compression, dynamically alters, and cardiac preload. So positioning and draping the patient usually prevents these manias. How everything is draped, how can you do external hepatic compression and all? So if you are not possible, give a 10 ml per kg bolus. This is what is an fluid response test. Don't give too much. Hyponatremia, hypernatremia, fluid overload, and dilutional anemia. This is very important because totally this child will have so much of blood volume is only 60-70 ml per kg. So 10 kg means already 700 ml. If you give 200 ml, see the dilutional anemia. That is not given importance usually in many books. So you should think of dilutional anemia. 1 hour after surgery, awake baby, feed the breastfeed. Early return to oral intake and enteral hydration should be encouraged. Now, if you are doing some herniatomy, appendicectomy for a kid of 6 years, get the baby out in 6 hours. If the baby's gut is wine, start oral intake. If you don't have, the isogenic balanced salt solution is dextrose. We know a 4-2-1 formula or a 2-2-1 formula. So major surgery, beware of hyponatremia. Acute illness, hypovolemia, nausea, pain, everything will stimulate ADH. Syndrome of inappropriate ADH secretion. Beware. Now we will go to clinical scenarios. Okay. Now a 3-year-old KG 15 kg is coming for circumcision, and that male has taken 2 hours prior 10 ml of clear juice. Okay, this is a small superficial surgery. The patient fasting guidelines is fine. So what is needed? No fluid, but just IV access is enough. And go back, do some sedation in its local block or caudal, then get the baby out, then start your breastfeeding or oral diet in 1 or 2 hours. So this patient does not need any IV fluids. Now, if you have a 3 kg neonate, anal surgery, 1 hour duration, breast milk is only 4 hours prior. Because we are dealing with neonate, we may anal surgery 1 hour duration, superficial surgery, but neonate, you may need to give 10 ml per kg over a period of 1 to 2 hours or 30 ml of 2 hours, 1% dextrose in oral because we are dealing with neonate. Okay, 100 ml oral, put 4 ml of 25% dextrose. You have 100 ml oral, put 4 ml of 25% dextrose. Now you have a 1% dextrose solution in oral. Give 30 ml of it in 24 hours. Now we have another child, 5 years, 22 kg, 6 hours faster for ulna plating. Okay. Now we have 22 kg, holiday cigar, 60 ml for 6 hours, 360 ml over a period of 2 hours. Now insensible loss is 1 ml per kg per hour because it's a superficial surgery. Insensible loss will be 4 to 5 ml if it is going to be a thoracotomy, or 7 or 8 if it is going to be a laparotomy. That's what I told previously. So 1 ml, it's another 20 ml. So around 360, 380 ml. This is going to be given over a period of 2 to 3 hours or 1 to 2 hours. And after that, you also correct blood loss. 6 months old, 8 kg child for intussusception, assessment and fluid. The patient will have vomiting for 1 day, heart rate of 145, delayed capillary filling, mild decrease in urine output. All these things are there for some good severe dehydration. Now you need to have rapid volume resuscitation. Previously, I told if you don't know anything and the volume status is just adequate, give 10 ml per kg bolus and see. Now you know that's a severe dehydration. Give 20 ml per kg for 20 minutes. For example, 8 kg means 20 ml is how much? 160 ml over a period of 20 minutes. Intravenous bolus. Now, children in hypovolemic shock may need multiple boluses. After 10 minutes, you may give another 20 over a period of 3 to 6 hours. If you cannot get an intraosseous line. Check sugar, creatinine, electrolytes for further management. Now, if you have a major laparotomy, because it is intussusception, preferable to have 10 ml per kg per hour. Blood for losses. A 2-year-old 10 kg child fasting 12 hours for VP shock. So 12 hours he has fasted because some problem in communication. 10 kg child. 12 hours means it's approximately how much? O modification because 20 ml per hour, so much don't give. 240 ml. 120 ml per hour and 120 ml per 6 hours. During the operation, you may add 10 kg child 5 ml per hour. So 50 ml per hour you can add. So this is 120 plus 50. Now we have O modification that comes as 240. This 240 has to be given within 2 hours. That is 120. Another 50 for operation, 170 ml per hour. So we need to add either 1% dextrose saline. Now we have pyloric stenosis. Isotonic crystalloids, 10-20 ml per kg, start giving because the patient will be taking food and immediately vomiting. They will be kept nil by mouth and almost nil by mouth even if you give something else. So there is a hydrogen loss, there is a potassium loss also here, other than hypoglycemia. So we need to have a crystalloid along with some potassium also. So sodium, potassium chloride corrected. Once the alkalosis is corrected, a fluid input is reduced to 100 ml per kg per. Give a bolus, and you may give up to 150 to 170 ml per kg per day. Then if alkalosis is corrected, then get down to 100 ml per kg. Why I am very particular about this is pyloric stenosis is a medical emergency. We need to treat, but you don't need to put the knife immediately. Correct your sodium, potassium, alkalosis. Get that down to get 20 ml per kg bolus, then 150 ml to 200 ml per kg per day. Then slowly come down to 100. Okay. Now we have 3-year-old 15 kg kid for hernia. Midnight fasting taken at 9 a.m. Now we have 9 hours fasting. Superficial surgery. 4-to-1 formula, 50 ml, 9 hours, 450 ml over a period of 2 hours. You may give 1% saline, then or ringer lactate. No introp, no post-op supplements. Get the baby out. If this baby would have taken good clear juice before 2.5 hours, then IV access may itself be enough. So I am again insisting one point. All these things also depend upon the anesthesia technique. Okay. Now, if your herniatomy is also given caudal, if your herniatomy is also given spinal, then we may need to replace some volume for that vasodilatation, even though the vasodilatation in kids is less than that of adults. So this is important. Just because the patient is coming for herniatomy, don't give any fluids is not correct. If you have been spinal correct, then you need to think about additional fluids. So people sometimes give super hydration. Instead of 10 ml, give 20 ml per kg per hour. And high doses may prevent PONV. Now you have a 1-day-old child. As soon as the baby is delivered, a big scalp because of the cesarean section. So you don't need to give any fluids at all. Some local and give suture it and give it to the breastfeeding. A 6-year-old 20 kg child for a foreign body eye, 2 hours fasting. 2 hours fasting is fine. So, a 7 years 25 kg adenotoxectomy, 7 hours fasting. Now first you go 6 years 20 kg. Okay, 2 hours fasting. 160 ml, 1 to 2 hours oral. That's enough. Now here 25 kg 65 ml per hour. 7 hours fasting is around 400 to 450 ml. That should be given in 1 to 2 hours. Either it is saline or 1% saline. How to make 1% glucose saline? 100 ml saline or 100 ml oral, put 4 ml of 25% dextrose. So what's the summary? They dehydrate fast, they have a large surface area, they need fluids more, they may have labile sugars, their gastric emptying is 1 hour, oral is okay, but when dextrose, preterm, neonates, hyperalimentation, major surgeries, liver failures, endocrinopathies, you need to add dextrose. Thank you very much for listening to me, and subscribe this Pain Free Partha. Thank you very much.